In this video, I am going to speak about a very important aspect of lymphocyte immunization therapy or LIT. What happens when LIT fails? Are we asking the wrong questions in these situations? LIT is supposed to improve the outcomes, but what about the cases where it doesn't? Is the treatment a problem, or are we missing something deeper than the immune evaluation? Let's see it today. I am Dr. Mohan Raut. I am a gynecologist and clinical reproductive immunologist certified by the American Society for Reproductive Immunology. We have our centers, Dr. Raut's Centers for Reproductive Immunology in Mumbai and in many other parts of India. At these centers, we treat couples with unexplained repeated miscarriages, recurrent IVF failures, and unexplained infertility with our patented and branded process of Immulit treatment. Now, as I said, LIT is supposed to improve outcomes in difficult infertility cases, and in many patients, it truly does. But let's address a slightly uncomfortable question. What about the cases where LIT fails? Is the problem the treatment itself, or are we perhaps asking the wrong immunological questions before using it? So, in reproductive medicine today, we are seeing a growing number of patients with recurrent implantation failure, repeated miscarriages, and so called unexplained infertility. Increasingly, these patients are being referred for immunological evaluation and for treatments like LIT. But somewhere along the way, LIT has started being used almost like a standard protocol rather than a precision immunological intervention. And that is where the problem begins. The first and the most important question we need to ask in this case is, are all RIFs and recurrent pregnancy loss patients truly immunological in nature? The answer is no. Even within immunological causes, the mechanisms are not uniform. Some patients may have alloimmune dysfunction, others may have autoimmune dominance, some may have inflammatory imbalances, and some may not have a significant immune component at all. So, when we apply the same LIT approach across all these patients, we are bound to see inconsistent results because we are treating a label, not the underlying immune mechanism. Now, this brings us to one of the most critical and often overlooked aspects: patient selection. LIT is not a universal solution. It is specifically designed to address alloimmune dysfunction where the maternal immune system fails to develop adequate tolerance to paternal antigens. If that mechanism is not clearly identified, then LIT may not give the expected outcome. So, when LIT fails, sometimes the real issue is not a failure of therapy, but a misalignment between the therapy and the indication. The next important factor is how LIT is actually performed. This is not just a procedure, it is an immunological intervention. Variables such as lymphocyte preparation, doses, administration techniques, and timing can all significantly influence the outcome. A lack of standardization or expertise can directly impact the effectiveness of the treatment. So, again, when LIT does not work, we must ask, was the technique optimized to begin with? But perhaps the most important question is whether LIT is used in isolation. Because in many patients, LIT is only one part of a much larger immunological picture. Some patients may require additional immunomodulation, control of inflammatory pathways, or even support for immune regulation during implantation and early pregnancy. If we rely on LIT alone without addressing the broader immune environment, we may be expecting too much from a single intervention. This is where individual visualization becomes absolutely critical. And this is exactly why we move towards a more structured, personalized approach with Immulate treatment. Not as just a procedure, but as a protocol driven by immunological understanding. An approach where all focus on correct patient selection, precise technique, and most importantly, individualized supportive immunomodulation. Because reproductive immunology is not about applying a treatment, it is about understanding the immune dialogue between the mother and the embryo. So, the next time we come across a case where LIT has not worked, instead of dismissing the therapy, it may be worth pausing and asking maybe uncomfortable question. Did we truly understand the patient's immunology? Did we select the right indication? Did we optimize the approach? Because sometimes the failure is not in the treatment but in the question we asked before using it. Reproductive immunology is evolving, and as clinicians, we must evolve with it. If you have found this useful, share it with someone who has been told everything is normal but still searching for answers. And if you want to understand whether immunology could be relevant in your case, you can reach out to us. You can contact us on 9833 201500 or 1522. You can also visit our website www.icprm.in and take our appointment. Please like and share this. Subscribe to our channel, Dr. Raut's Center for Reproductive Immunology. Thank you.